Thank you very much to the World Congress Organizing Committee for the invitation to share our work on correlates of plasma NT-probnp to cyclic GMP ratio in heart failure with preserved ejection fraction from the RELAX trial. I am Deepak Gupta, a cardiologist at Vanderbilt University Medical Center in Nashville, Tennessee, USA. Here are my disclosures. Cyclic GMP is the second messenger which mediates the cardiovascular, renal, and metabolic protective effects of the natriuretic peptide NP and nitric oxide NO pathways. Cyclic GMP activates protein kinase G, leading to downstream smooth muscle relaxation to cause vasodilation. Other beneficial effects of this pathway include reducing inflammation, reducing hypertrophy and fibrosis, and renal protection. Cyclic GMP production occurs through soluble and particulate guanylate cyclases. Cyclic GMP degradation occurs via phosphodiesterases. Phosphodiesterase 5 is thought to degrade cyclic GMP produced by the NO-SGC pathway, while phosphodiesterase 9 impacts the NP-PGC pathway. In response to cardiovascular stress, the heart produces and releases NP, which should raise cyclic GMP levels and result in the downstream cardioprotective effects of natriuretic peptides. This feedback loop is a compensatory mechanism to allow responsiveness to acute and chronic stressors on the cardiovascular system. It is also leveraged clinically with circulating NP levels used as biomarkers in the diagnostic evaluation of heart failure and prognostication. This NP cyclic GMP counter-regulatory feedback loop may be deficient, however, if cyclic GMP levels are relatively low for the level of NP stimulus. Indeed, heart failure may be a condition of relative cyclic GMP deficiency, despite higher circulating NP levels, as it can be characterized by hypertrophy, diastolic dysfunction, vascular dysfunction, insulin resistance, inflammation and immune dysfunction, adiposity, and renal dysfunction. Cyclic GMP deficiency appears to be prognostically significant as well. Among patients with heart failure with reduced ejection fraction who participated in the Paradigm trial, which tested combined ARNI against ACE inhibition, those in the lowest tertile of cyclic GMP to BNP ratio at baseline experienced the highest incidence of adverse cardiovascular outcomes, which was evident even within the first few months after the onset of follow-up. In further support of this concept of relative cyclic GMP deficiency, therapeutically augmenting the NP cyclic GMP pathway through neprilysin inhibition or soluble guanylate cyclase stimulation is an effective therapeutic approach in patients with symptomatic HFrEF based on results from the Paradigm and Victoria trials respectively, as shown here. In contrast, neprilysin inhibition and soluble GC stimulation have been relatively less effective among patients with heart failure with preserved ejection fraction. This raises the possibility that degradation of cyclic GMP by phosphodiesterases may blunt downstream cardioprotective effects mediated through the second messenger. Several phase 2 clinical trials of patients with HFpEF have targeted the NO-SGC-PDE5 pathway, such as NEAT, INDY, and CAPACITY, with consistently neutral results. In contrast, natriuretic peptides are typically increased in the setting of HFpEF, and the Paramount and Paragon trials testing neprilysin inhibition had comparatively more positive results. However, NP to cyclic GMP ratio and its phenotypic correlates among patients with HFpEF are not well understood. Specifically, few data exist in the setting of HFpEF regarding 1. The distribution and concentrations of cyclic GMP in the circulation, 2. The relationship between circulating NP and cyclic GMP levels, 3. Clinical correlates of NP to cyclic GMP ratio, and 4. Whether NP to cyclic GMP ratio modifies the effect of treatments targeting phosphodiesterases. The RELAX trial tested phosphodiesterase 5 inhibition to improve clinical status and exercise capacity in heart failure with preserved ejection fraction. The overarching hypothesis was that augmentation of cyclic GMP through blockade of its breakdown by sildenafil improves peak oxygen consumption, left ventricular mass, and other patient-oriented outcomes in HFpEF. Using publicly available RELAX trial data, we examined 1. The cross-sectional correlates of NT-probnp to cyclic GMP ratio, 2. Whether sildenafil changed the NT-probnp to cyclic GMP ratio, and 3. Whether baseline MP to cyclic GMP levels modified the effect of sildenafil on trial outcomes. NT-probnp to cyclic GMP ratio could be calculated in 98% of the 216 patients at randomization. The unadjusted relationship between plasma cyclic GMP in relation to NT-probnp is displayed in this scatter plot, which did not reveal a significant correlation. This suggests uncoupling of the expected NP cyclic GMP relationship in patients with HFpEF. A sample of baseline characteristics according to quartile of NT-probnp to cyclic GMP ratio are shown here. The ratio of NT-probnp to cyclic GMP range from approximately 1 to 50 with a median ratio of approximately 9. Patients with higher NT-probnp to cyclic GMP ratio were older, more likely to have a history of atrial fibrillation, and less likely to have COPD. Patients with higher NT-probnp to cyclic GMP ratio were also more likely to have lower eGFR and higher circulating markers of myocardial injury and fibrosis evident by troponin I, collagen-related markers, and galectin-3. Peak VO2 also declined in relation to higher NT-probnp to cyclic GMP ratio. Cardiac parameters were also more likely to be worse in patients with higher NT-probnp to cyclic GMP ratio. For example, transmitral E wave velocity, E to A ratio, E over E prime ratio, left atrial volume, and right ventricular systolic pressure were all more severe in relation to higher NT-probnp to cyclic GMP ratio. Following these unadjusted analyses, we performed multivariable adjusted models to examine correlates of NT-probnp to cyclic GMP ratio. As shown here, we found greater LV mass significantly associated with higher NT-probnp to cyclic GMP ratio. In contrast, LVEF was not significantly associated with the NT-probnp to cyclic GMP ratio. Peak VO2 and eGFR both significantly and inversely associated with NT-probnp to cyclic GMP ratio. BMI also inversely associated with NT-probnp to cyclic GMP ratio, such that leaner individuals had higher ratios and obese individuals had lower ratios. Individuals with a history of atrial fibrillation also displayed higher NT-probnp to cyclic GMP ratio. This pattern of correlates was not only present at baseline, but also at 24 weeks, even when accounting for randomization assignment to sildenafil or placebo. Next, we sought to examine the 24-week change in NT-probnp to cyclic GMP ratio according to randomization assignment. In unadjusted and adjusted analysis, NT-probnp levels increased from baseline to week 24 in those randomized to sildenafil compared with placebo, but neither cyclic GMP nor NT-probnp to cyclic GMP ratio significantly changed. To address our fourth question, we examined whether baseline NT-probnp to cyclic GMP ratio modified the treatment effect of PDE5 inhibition with sildenafil on outcomes in RELAX. We did not, however, find significant interactions on the outcomes of peak VO2, LV mass, and clinical composite rank score, or on eGFR or troponin. Phosphodiesterases degrade cyclic GMP, the second messenger that mediates the cardioprotective effects of NP. High NP to cyclic GMP ratio may therefore reflect, in part, greater phosphodiesterase activity. Therefore, we investigated correlates of circulating NT-probnp and cyclic GMP ratio among patients with HFpEF enrolled in the RELAX trial. Our principal findings were 1. Higher NT-probnp to cyclic GMP ratio associated with an adverse cardiac and renal phenotype characterized by higher LV mass, atrial fibrillation, lower eGFR, and lower peak VO2. 2. Selective inhibition of phosphodiesterase 5 with sildenafil for 24 weeks did not change the NT-probnp to cyclic GMP ratio. And 3. Baseline NT-probnp to cyclic GMP ratio did not modify the effect of sildenafil on trial outcomes. Collectively, these results suggest that other phosphodiesterases may be relatively greater contributors than phosphodiesterase 5 to the adverse phenotype associated with a high NP to cyclic GMP ratio in HFpEF. Among patients with HFpEF, we found an adverse cardiac and renal phenotype associated with higher NT-probnp to cyclic GMP ratio. More specifically, patients with higher NT-probnp to cyclic GMP ratio were more likely to have greater LV mass, lower peak VO2, and greater renal dysfunction. which are each established markers for worse prognosis in patients with HFpEF, as shown in the bottom row of figures. Appreciating that threshold NP levels are often used as eligibility criteria for heart failure trials, but cyclic GMP levels are not clinically measured, knowledge of these phenotypic correlates of higher NP to cyclic GMP ratio could potentially further refine patient selection to those most likely to benefit from interventions targeting this pathway. This may be particularly relevant in patients with HFpEF, in whom relatively few therapeutic options have proven efficacy in clinical trials. Despite similar associations between a higher NP to cyclic GMP ratio and an adverse cardiac phenotype in both human HFrEF and HFpEF, to date their respective therapeutic response to cyclic GMP augmentation have differed. Indeed, therapeutic strategies to augment cyclic GMP, such as soluble guanylate cyclase stimulation with vericiguat and neprilysin inhibition with sacubitril, have demonstrated efficacy to improve clinical outcomes in HFrEF, as I showed earlier from the Paradigm and Victoria trials. In contrast, trials in patients with HFpEF testing augmentation of the NO-SGC pathway yielded consistently neutral or even harmful results with regards to physical activity. Neprilysin inhibition with sacubitril appears to be more effective in subsets of patients with HFpEF based on the Paragon trial. And although the mechanism for this is uncertain, the results raise the possibility that targeting the NP-PGC-generated cyclic GMP pool may be of greater potential therapeutic benefit to some patients with HFpEF. PDE5 and 9 selectively degrade cyclic GMP and therefore present different pathways for therapies to target. Preclinical evidence from Lee, Cass, and colleagues demonstrated PDE5 to be selective for the NO-SGC-generated cyclic GMP pathway, while PDE9 regulates the NP-PGC cyclic GMP pool. Although evidence suggested increased PDE5 expression and activity in preclinical models of LVH and HFpEF, the overall results from the RELAX trial testing selective PDE5 inhibition with sildenafil among patients with HFpEF was neutral. In the current analysis, we examined whether baseline NT-probnp to cyclic GMP ratio modified the effect of sildenafil on 24-week outcomes, but did not find this to be the case. These results, in concert with findings from the INDY and NEAT HFpEF trials and aforementioned evidence demonstrating PDE5 to be selective for the NO-SGC-generated cyclic GMP pool, suggest the NO-SGC PDE5 pathway may not substantially contribute to cyclic GMP deficiency among patients with HFpEF. Lee, Cass, and colleagues also found myocardial PDE9 expression levels to be increased in humans with HFpEF, relatively more so than in patients with HFrEF as well as aortic stenosis, and further that PDE9 may be more selective for the NP-PGC-generated cyclic GMP pool. Across a variety of other preclinical models of HFpEF, including angiotensin II, uniphorectomy plus D-aldosterone, and the DB-DB obesity model, we found PDE9 transcript abundance is also greater in myocardium compared with sham controls. PDE9 also has greater affinity for cyclic GMP compared with PDE5, further supporting PDE9 as a potential therapeutic candidate in HFpEF. Preclinical studies involving PDE9 inhibition through knockout, silencing, and ours with pharmacologic blockade in HFpEF models provide promise for the utility of targeted PDE9 inhibition for the prevention and treatment of patients with HFpEF. The data shown here are with an oral PDE9 inhibitor, tovinontrine, which demonstrated slowed progression or reduction in LV mass and cardiomyocyte size across all 3 mouse models. Oral PDE9 inhibition in these mouse models also caused significant improvements in renal protection, evident by lower blood urea nitrogen levels and lower urine albumin to creatinine ratio. A phase 2 randomized clinical trial testing selective PDE9 antagonist CRD50 using tovinontrine began enrolling patients with heart failure across the spectrum of LVEF in 2024, with enrollment completed earlier this year. Whether selective PDE9 inhibition lowers NT-probnp, the primary endpoint in these studies, and whether trial participants with an adverse cardiac and renal phenotype indicative of high NP to cyclic GMP ratio have the greatest response to PDE9 inhibition remains to be elucidated. Despite the neutral results of RELAX in patients with HFpEF, stimulating the NO cyclic GMP side of this pathway with vericiguat improved outcomes in the phase 3 Victoria trial of patients with HFrEF. This raises the intriguing possibility that combined PDE5 and PDE9 inhibition may be efficacious in some patients with HFrEF. Dr. Richards in New Zealand has pioneered much of the experimental work investigating these concepts. His lab is adept at large animal models of heart failure and used the sheep model of rapid pacing-induced heart failure to investigate the combined effects of acute PDE5 and PDE9 inhibition on hemodynamics, plasma levels of NPs and cyclic GMP, and natriuresis and diuresis. With this design, his group found combined PDE5 and PDE9 inhibition markedly increased circulating cyclic GMP levels and cyclic GMP to NP ratio, with a corresponding augmented reduction in systemic vascular resistance and arterial pressure, marked reduction in pulmonary artery pressure, reduction in left atrial pressure, and increase in natriuresis and diuresis. Dr. Richards' group also examined combined augmentation of NPs with ARNI and PDE9 inhibition. Using a similar design to the prior study of combined PDE5 and PDE9 inhibition, Dr. Richards' group examined ARNI and PDE9 or both in the sheep model of pacing-induced heart failure. They found combined ARNI and PDE9 inhibition markedly increased circulating and urinary cyclic GMP levels with a corresponding augmented reduction in total peripheral resistance and mean arterial pressure, marked reduction in left atrial pressure with increase in cardiac output, and increase in natriuresis and diuresis. Whether improvements in these parameters through combined ARNI and PDE9 inhibition would be seen in HFpEF has not yet been reported. In conclusion, among patients in the RELAX trial, the lack of impact of sildenafil to alter the NT-probnp to cyclic GMP ratio or trial outcomes suggests other PDEs may be relatively greater contributors than PDE5 to the adverse phenotype associated with a high NP to cyclic GMP ratio in HFpEF, with PDE9 being a promising candidate. Combined targeting of the NO-NP cyclic GMP pathway may be a promising approach for patients with heart failure and relative cyclic GMP deficiency. Understanding clinical correlates of relative cyclic GMP deficiency may inform patient selection for clinical trials and hold promise for more tailored alignment of therapies with an individual's patient's pathophysiology. Thank you very much to my colleagues who co-authored this work and our past and current sources of funding and data. And thank you again to the organizing committee and all of you in attendance for your time and interest.